This is one of the videos that I call You Must See. Um, so I'm going to go over Saphenous nerve all the way from its origin to the foot, and I'm going to cover the adductor canal, and I will cover also some branches from the saphenous nerve. So let's get started here. Okay, so the saphenous nerve, as we know, if we go back to the origin, it is from L234. It's a branch from the femoral nerve in the femoral triangle. And as you see, you can block this nerve anywhere from the perifemoral area to subsartorial here in the femoral triangle, adductor canal, then block it near the femoral condyle, medial femoral condyle, and here you can block it also around the knee, paravenous below the knee, and around the medial malleus. So in the thigh, there are three important regions: the iliopectineal fossa, the femoral triangle, which we see here, and the adductor canal. So the femoral triangle, the base of the triangle is the inguinal ligament, as we see in the picture. The medial border is the medial margin of the adductor longus muscle, which is this one here. And the lateral margin is the medial margin of the sartorius muscle. The floor is formed medially by the pectineus and adductor longus muscle in the medial compartment of the thigh, and laterally by the iliopsoas muscle descending from the abdomen. The apex point inferiorly and is continuous with the a facial canal called the adductor canal. So the region between the apex of the iliopectineal fossa, right there, and the apex of the femoral triangle, this region we call it distal femoral triangle. Distal femoral triangle, which is about 10 centimeters. The apex of the femoral triangle is the most distal aspect of the femoral triangle and the cephalid margin of the beginning of the adductor canal. So here, the end of the femoral triangle and the beginning of the adductor canal, which extend distal to the adductor hiatus. So that in the adductor hiatus, the femoral artery descends through the adductor hiatus to enter the posterior compartment of the leg and continue as the which is the posterior fossa, popliteal fossa, and continue as the popliteal artery. So the adductor canal, it varies between references, which makes sense. It varies between people. It's anywhere between 8 to 15 centimeter. So what's the adductor canal? Also known as the Hunter canal. It's an aponeurotic space between the distal femoral triangle and the adductor hiatus in the adductor magnus muscle. So the boundaries, as you see from above, you have the sartorius muscle. From lateral, outside, you have the vastus medialis. And from inside or medial, you have the adductor longus and adductor magnus. If you want to be more specific, you have the vasoadductor membrane anterior-medially. You have the fascia of the vastus medialis anterolaterally, and you have the fascia of the adductor longus and magnus posterior-medially. A aponeurotic structure called the vasoadductor membrane forms the roof of the adductor canal. This is also important when we start to talk about the block. Now, to summarize the difference between the femoral triangle and adductor canal, how we differentiate between them, because you will see this is very clinically important when we start to look at different nerve block. So the femoral triangle, the sartorius muscle form the lateral margin, while in the adductor canal, it is anterior-medial, or the roof, if you wish. The adductor longus muscle, here it's in the floor, it's medial, it's a big muscle. Here it's posterior medial and start to get smaller until it disappear. The vastus medialis does not exist in the femoral triangle. However, it's very important in the adductor canal. It forms the anterior lateral border. It's a large muscle. Femoral artery and vein, we will go over this multiple times in this video. Here it's mostly medial, here underneath and lateral. And of course, the content are different. So in the adductor canal, you have the femoral artery, vein, and the saphenous nerve only. And in the femoral triangle, you see the nerve and its branches, the artery, the vein, some lymph nodes, and the femoral nerve, of course, bifurcate here. So what about the medial and intermediate cutaneous nerve of the thigh? So in this picture here, they removed the skin and subcutaneous tissue. So what you see here is the fascia lata wrapping around the entire thigh. So the intermediate femoral cutaneous nerve appears the fascia lata as two separate branches close together, close to anterior, as you see here, two separate branches close together anterior to the sartorius muscle. The posterior branch of the medial femoral cutaneous nerve pierces the fascia lata on the distal medial part of the thigh. The anterior branch of the medial femoral cutaneous nerve pierces the fascia lata anterior to the sartorius muscle. So that's the sartorius anterior, somewhat distal to the piercing of the sartorius muscle by the intermediate femoral cutaneous nerve. After the intermediate femoral cutaneous nerve and medial femoral cutaneous nerve branches have pierced the fascia lata, they ramify and innervate the subcutaneous tissue of the skin, as you see here. Now, the intermediate femoral cutaneous nerve pierces the iliopsoas fascia as one nerve, which is right there, just distal to the inguinal ligament before it's split into two branches. The most lateral of the intermediate femoral cutaneous nerve branches pierce the sartorius muscle, and here we see the sartorius muscle removed in this picture. So the medial femoral cutaneous nerve pierces the iliopsoas fascia here, more distal and at a deeper level compared with the intermediate femoral cutaneous nerve. The medial femoral cutaneous nerve is adjacent to the saphenous nerve and the medial vastus nerve anterior lateral to the femoral artery until the femoral artery dives deep to the medial margin of the sartorius muscle. At that level, the medial femoral cutaneous nerve starts crossing anterior to the femoral artery and split into two branches, posterior and anterior. The posterior branch of the medial femoral cutaneous nerve follow the medial margin of the sartorius muscle, while the anterior branch of the medial femoral cutaneous nerve pierces the sartorius muscle. Now, the blue arrow here indicate the level of the distal femoral triangle block, correspond to the midpoint between the anterior superior iliac spine and the base of the patella. This is consistently proximal to the apex of the femoral triangle and the proximal border of the vasoadductor membrane indicated by the green arrow. The block at this level anesthetize the saphenous nerve and the vastus medialis nerve, while the red arrow here indicate the proximal femoral triangle block, which anesthetize the medial femoral cutaneous nerve, the saphenous nerve, and the medial vastus nerve. So this is another illustration of the adductor canal. So if you look at the adductor canal, what's entered the adductor canal, again, the saphenous nerve, the femoral artery and femoral vein. So if you look proximal canal, you will see the saphenous nerve present. Nerve to vastus medialis always outside the canal. If you go mid-side the canal, the saphenous nerve to leave, and if you go all the way distal, the saphenous leave, and you kind of have the obturator start to go closer to the canal. Now, this is a very important article that discusses the pro and con, how important is the exact location of the adductor canal and femoral triangle block. And what they found here that the pro side of the debate support the view that more distal block location in the anterior thigh increase the risk of excluding the medial and intermediate cutaneous nerve of the thigh and the nerve to the vastus medialis, while increasing the risk of spread to the popliteal fossa, making the distal femoral triangle block the preferred location. The con side of the debate adopt the view that while the exact location of local anesthetic injection appear anatomically important, it has not been proven to be clinically relevant. And in my opinion, if you think about that, and I always tell my fellow this when I teach them the difference between the nerve block, putting a catheter versus doing a peripheral nerve stimulator. So when you put a local anesthetic in the canal, you put 15 ml, for example, that will travel up or down, and most likely it can cover the nerves that even you did not intend to block. So if you go outside the canal and you put some medication that will reach the vastus medialis, again, it depends on the volume. So this is why, in my opinion, that difference, although anatomically makes sense, clinically didn't make a big difference. Now, is that true for peripheral nerve stimulator placement? Absolutely not. When we do peripheral nerve stimulator, it is very important to distinct about and found these nerves one by one, because as you've seen in my peripheral nerve stimulation lecture, most of the leads, they have short electrodes, and you have to be very close to the nerve. So if you just go, let's say, mid-adductor canal, you catch the saphenous, you're not going to catch the nerve to vastus medialis. So this is why the level become more important. So you may need to go more up toward the distal femoral triangle and localize both nerves, stimulate them both, make sure you are happy with the stimulation. So let's shift gear and talk about saphenous nerve pain or neuralgia. As we know, the saphenous nerve is a pure sensory nerve. It innervates the medial aspect of the leg and the foot and the knee, of course. So when you have a neuralgia, of course, you have pain and probably numbness, neuropathic pain, and the distribution of the nerve. Causes of injury, many. Total knee replacement, above knee amputation, any surgery along the course of the nerve, Hunter canal syndrome, which is nothing but saphenous entrapment neuropathy in the distal thigh at the Hunter canal, and neuroma or entrapment of the infrapatellar branch of the saphenous nerve. So this is, I went through this in my introductory lecture for the lower extremity, and I will have a separate lecture talking about knee pain or chronic knee pain. But this is just to pave the way so we can start about talking about these nerves. So my approach when I have, again, chronic post total knee replacement pain, it's a good idea to start genicular nerve, which we're not going to cover in this specific video, then I divide divide the knee into 3/3. If the pain mostly in the inner third or medial third, I go with saphenous, then middle nerve to vastus medialis, then nerve to vastus lateralis, and if it's below, I will go with the infrapatellar nerve. So the good news in this video, I will show you how we block and place a stimulator for the saphenous nerve, for the vastus medialis, for the vastus lateralis, and for the infrapatellar nerve. So let's get started. Adductor canal, when we talk about saphenous nerve, we always talk about adductor canal, which is an interfacial plane block performed at the level, most likely at the mid-thigh. Now, this a nice infographic that you can save and refer to. However, let's get started. So when you start scanning, always have a systematic way. So put your ultrasound probe around mid-thigh, from the anterior superior spine to the knee, and find the femur bone. So once you find the femur bone, that's lateral, that's medial, then you start to slide medial until you find the femoral artery and femoral vein. At that level, you should see the sartorius muscle above them, vastus medialis lateral, and the adductor longus and magnus, they will be medial, right? Adductor makes sense, they are medial muscles. And here, beautiful picture here, even you can see the vasto-adductor membrane, which is this blue line. And then you see the fascia of the vastus medialis, the yellow line, and the fascia of adductor longus, the orange line. So this is the boundaries of the adductor canal as we discussed earlier. And if you notice here that the saphenous nerve just lateral to the vessels, and somewhere here you should see the nerve to vastus medialis outside the adductor canal. This is more clear picture, so that's in the yellow, that's the nerve to vastus medialis, and in the orange, that's the saphenous nerve. So you have what we call it transsartorius versus infrasartorius, and that just to tell you. So we are coming from lateral to medial. If you go through the sartorius muscle, we call that transsartorius. If you start a little bit lateral and you just go underneath it, that's called infrasartorius. From my experience, it's less painful to go with the infrasartorius. It's more sensitive to go through the sartorius muscle. I'm not aware about research, but that's a personal experience. So I would go more lateral, don't go through the sartorius, and go from this angle. And then you see the saphenous nerve here, and you inject. This is local, which anywhere 15 to 20 ml should be fine. Now let's move up and down. Let's see the adductor canal. So this is very important. So now at this ultrasound picture, we are at the apex of a femoral triangle. So this is A. So now we are at the apex of the femoral triangle, as you see in the illustration as well. And here, if you note in the ultrasound picture, there is the point of intersection of the medial border of the sartorius muscle and the medial border of the adductor longus muscle. So the adductor longus muscle almost end here. So what you notice also that the vessels, the artery and the vein, sorry, that's the adductor longus here, that's the magnus, they are more medial to the sartorius. Now we move to B, which is at the level of the mid-adductor canal. Here you notice how the vessels moved slightly lateral, and both the adductor longus and magnus muscles are noticeable. So longus, magnus, underneath there. If you go farther down here at C, you are at the level of the distal end of the adductor canal. So you notice you don't have adductor longus anymore. You only have adductor magnus. And notice where are the vessels now? The vessel is now lateral to the sartorius. So let's put this together. I spent some time putting together this table to help you differentiate. So here, A, the apex of the femoral triangle, this is A, this is A. So relationship of the femoral artery and femoral vein to the sartorius. As I see, I put here roughly this sign here, like almost medial, right? Almost medial. When we go down to B, which is mid-thigh, mid-adductor canal, the vessels mostly underneath. As we go down to the distal, they become more lateral. If we look at the adductor longus, which is another important landmark, it is present at the apex, the mid-adductor canal, then it vanishes on the distal. If you look at the adductor magnus, it's present in almost all these levels, but it's hard to see when you are at the apex of the femoral triangle, unless if you go more medial. So I hope this is helpful, just so when you put your ultrasound, look at the vessels location compared to the sartorius muscle, and look at the presence of the adductor longus and magnus. Okay, so here just a chronic pain patient presented with Hunter canal syndrome, which is an entrapment of the saphenous nerve in the canal. And this show you how they treated it with hydrodissection around the nerve. Okay, let's shift gear and talk about the infrapatellar nerve, which is a branch of the saphenous nerve, usually travel lateral just underneath the patella. This branch of the saphenous nerve is purely sensory. The whole saphenous nerve is sensory and is at risk of iatrogenic damage during total knee replacement because of the retractor position, incision, etc., etc. It exits the sartorial fascia at the distal end of the Hunter canal. So around here you see it exit. Then it travels between the superficial fascia and the sartorial. So it's above the sartorius muscle. And you see the nerve and its branches off here. And then here's another illustration that show you the two terminal branches, the superior and inferior branch. And again, it's a pure sensory. It arises from the saphenous and the subsartorial canal here, subsartorial canal, and it pierces the fascia anterior through the sartorius muscle. The sartorius muscle is moved a little bit so you can see the nerve. And then here, here you see the infrapatellar branch. So this is the sartorius, right? This is the vastus medialis. Here the saphenous, it's above at this level. More here, it's a longitudinal view. You see the nerve. Here more images of the infrapatellar. So again, now it get above the sartorius. So this is the fat and subcutaneous tissue. And here when you block the nerve. This is another picture. Again, this is the superficial fascia. This is the fascia of the sartorius muscle, and you see the nerve between the superficial fascia and the sartorius muscle. Here, this case show you, this is more medial view, so you see This is the femur, this is the tibia. In this case, there is a neuroma attached to the nerve that eventually got removed surgically. In this specific reference, they mentioned that it's very common, up to 84%. Maybe that's overestimation, but the point it's a common, so you need to think about it. Now let's look at the saphenous nerve below the knee. So below the knee, anterior and medial, you see it's very superficial, running with the saphenous vein. And then if you go to the ankle level, it is still very superficial. This is we are looking. This is the medial malleolus. This is anterior to the medial malleolus. You see the nerve with the vessels very clear with the vein. This is another image here, and you can come from posterior to anterior to block the nerve. Very easy. Now I will wrap up this lecture with vastus lateralis nerve. So the vastus lateralis, the way you find it, go to the upper 1/3, almost at the junction between the upper 1/3, the middle 1/3 of the thigh. Again, find the femur and start to move lateral this time. So start to scan lateral. And what you need to localize is the descending branch of the lateral circumflex femoral artery. And sometimes it's two branches here. And then you will see the nerve to vastus lateralis running with that. So it's in the layer underneath the rectus femoris, above the vastus intermedialis. So if you remember, this is the lateral circumflex artery right there. It gives you 3 branches, right? The descending branch, which is the important landmark here, even if you remember from my first lecture. So now if you scan down, you see the vastus lateralis now coming lateral to the rectus femoris, but it's always above vastus intermedialis, and it's still running with the vein. So, with the artery. So you can block it at this place. You can place a peripheral nerve stimulator here as well. Thank you for watching, and I hope you found this very helpful.